Okay, let's unpack this. When we talk about a successful total knee replacement, a TKR, um, it's easy to focus just on the operation itself, right?
Right.
But what really makes it work for the patient, long term, beyond the surgery day.
Exactly.
Today, we're sort of stepping inside the OR metaphorically to look at the incredible precision needed. Bone cuts,
Right.
alignment. It's fascinating stuff. We're drawing on some expert notes about surgical best practices here.
And it's so important to understand why all this precision matters. I mean, it's absolutely critical for how well you do as a patient and how long that new knee actually lasts.
Okay.
The real goal isn't just swapping out parts, it's about carefully restoring your knee's natural mechanics, making it feel and work like your knee should.
So focusing on that alignment piece in TKR.
Yeah.
What's the ultimate target? What are surgeons actually trying to achieve inside there?
Well, there are three main things, really. First, you've got the mechanical axis. We need to restore that.
That's the straight line, hip to ankle.
Precisely. Hip center, through the knee center, down to the ankle center, perfectly straight. Think of it as the leg's true alignment.
Got it.
Second, you need balanced soft tissue tension. The ligaments and tendons, everything needs to be nicely balanced around the new joint.
Makes sense.
And third, ensuring the right femoral tibial alignment. Usually that means neutral, straight on, or maybe just a touch valgus.
Valgus. It's slightly knock-kneed?
Sort of, yeah. A slight outward angle from the knee down, matching the leg's natural subtle curve for many people.
Okay, that clarifies it. But I gather there's not just one single way to get this alignment spot on. This is where it gets really interesting, right? Different philosophies.
Oh, absolutely. It's a big area of discussion. You've got the mechanical approach first. That's all about hitting that perfect 0-degree mechanical axis. Pure geometry.
Universal standard.
Kind of, yeah. Then there's the anatomical way. This one accounts for the fact that your femur, your thigh bone, naturally has a bit of a bow, usually around 6 degrees, so it builds that in. Then you have kinematic alignment. This is quite different. It focuses on resurfacing the joint to replicate your specific original joint line and how your ligaments felt before arthritis. Very individualized.
Trying to recreate the original feel.
Exactly. And finally, there are functional or hybrid methods. These try to blend the mechanical and kinematic ideas, looking for a practical balance.
So different paths.
But all aiming for precision for your knee, ultimately. That's the constant.
It really does sound like artistry. So let's talk bone. What does all this mean for the femur, the thigh bone, during the operation? What are those cuts like?
Okay, the femur cuts are super specific. The end of the femur, the distal femur, we usually resect or cut off about 9 to 10 millimeters.
And that's not random.
Not at all. It's calculated to match the thickness of the femoral part of the implant. It restores the joint space. And crucially, this cut is perpendicular to that mechanical axis we talked about.
Right.
Which means it has that slight valgus angle, maybe 5 to 7 degrees, compared to the bone's own axis. Then you have the anterior and posterior cuts, front and back.
These are vital for getting the rotation right and making sure your kneecap tracks smoothly. We use landmarks on the bone, like the epicondylar axis or Whiteside's line, to guide these.
Okay.
And lastly, there are chamfer cuts. These are angled cuts that shape the bone end so the implant fits snugly, like a key in a lock.
Wow, the detail is amazing. What about the tibia then, the shin bone? Is it a similar story down there?
Very similar in terms of needing precision, yes.
Yeah.
For the proximal tibia, the top part, we cut perpendicular to the mechanical axis again, usually taking off about 8 to 10 millimeters just below the outside plateau.
Okay.
But a really key detail here is the posterior slope, the angle of the cut from front to back.
Why does that slope matter so much?
It affects how the knee bends and feels. For cruciate retaining implants, or CR, where you keep a key ligament, the slope is typically around 3 degrees. For posterior stabilized or PS implants, which have a mechanism to do the ligament's job, it's usually flatter, maybe 0 to 3 degrees. It depends on the specific implant design. And getting the spin right, the rotation, sounds like it ties everything together. How do surgeons nail that?
Yeah, rotational alignment is critical for function. For the femur, we use those bony landmarks, again, the posterior condyles, the epicondyles, Whiteside's line.
Right.
For the tibia, we often align it looking down the leg, maybe pointing towards the bump below your kneecap, the tibial tuberosity, or even lining it up with the second toe.
Huh. Interesting reference points.
They all help ensure everything rotates together correctly so your kneecap glides smoothly and you don't get pain or wear.
Right.
And bringing all these details together, the axis, the tension, the slopes, the rotation, it all comes back to one thing for you, the patient.
Which is?
Restoring that neutral mechanical alignment. Doing that well is proven to directly improve how long the implant lasts.
So the flip side, what if a cut is off by just, say, a millimeter or a degree? What happens then? What are the risks?
Even small errors can cause big problems. You might get flexion instability, that feeling of the knee giving way when it's bent, or maltracking, where the kneecap rubs or grinds. Painful. And the big one is early loosening of the implant, which could mean needing another major surgery much sooner than expected. That's why things like robotic assistance or navigation systems are becoming, well, increasingly valuable. They help surgeons achieve that near-perfect accuracy more consistently.
This deep dive really underscores that TKR is this incredible mix of engineering and biological artistry. And that precision isn't just a detail, it's absolutely fundamental for the patient's outcome, for their quality of life.
It really is. And thinking about that precision, it makes you wonder, doesn't it? What other medical technologies, maybe like those navigation systems we touched on, are quietly changing procedures we think of as routine? And, how might these innovations fundamentally reshape healthcare down the road?